Let's dive right into this. Welcome to this explainer, where we're going to look at the chest exam in a totally different way. You know, so often, we're taught to treat clinical bedside signs as this massive, intimidating list of facts we just have to cram into our brains. But actually, as we dig into this today, it turns out it's not about rote memorization at all. It's actually this brilliant, perfectly logical physics puzzle playing out right inside the human anatomy. So today we're going to decode lung sounds by breaking them down from first principles. And I promise you, by the end of this, the things we all use to memorize will just make complete, intuitive sense.
Okay, picture this scenario. You ask a patient to whisper 111 while you listen over their chest with your stethoscope. In a normal, healthy lung, you're going to hear almost nothing distinct, just a very faint, kind of muffled murmur. But then, you move your stethoscope over a sick, consolidated lung lobe, and that exact same whisper comes through with this startling, almost eerie clarity. I mean, it literally sounds like the patient is whispering directly into the earpieces of your stethoscope. This phenomenon is called whispering pectoriloquy. It genuinely feels like a magic trick, but it's entirely based on one very simple law of physics.
So, what is it? The foundational fact that explains almost everything we're going to cover today is super simple. Sound travels faster and, frankly, far more efficiently through solid mediums than it does through air or fluid. Why? Well, because the molecules in a solid are packed tightly together, and that allows them to transmit vibrational energy with very little loss. Air, on the other hand, it's scattered. It's an absolutely terrible conductor of sound. I want you to keep this one rule locked in your mind because it is literally the master key to unlocking the entire respiratory exam.
Here is our roadmap for today. We're going to cover the physics of lung sounds, the signs of lobar consolidation, lobar collapse, and tracheal shift, the obstructive pneumonitis trap, and finally, the updated pneumonia treatment guidelines.
All right, Section 1. The physics of lung sounds. Let's establish our baseline mechanics.
To understand what's abnormal, we first have to really appreciate healthy mechanics. Think about a normal lung. It is mostly filled with air. And as we just learned, air is a really poor conductor of sound. This is exactly why, normally, breath sounds and spoken words arrive at your stethoscope muffled, filtered, and indistinct. The lung basically acts as a natural acoustic muffler. But now, contrast that with a consolidated lung. Consolidation just means that the air in the alveoli has been replaced with solid, exudate-filled tissue, which happens a lot with an infection like pneumonia. So suddenly, you've replaced a poor sound conductor with an excellent, solid sound conductor. That natural muffler, it's gone. And the lung becomes a highly efficient acoustic amplifier.
Moving to Section 2, signs of lobar consolidation and the derived bedside signs.
Now that we have a grip on the physics, let's see how this builds, mechanically speaking, inside the chest. Step 1, the tiny air sacs, the alveoli, fill up with solid exudate tissue. But here is the critical part, Step 2. The large airways, the bronchi actually feeding that lobe, remain open or patent. So then we hit Step 3. The loud, harsh central breath sounds generated up in the trachea and large airways now travel directly through those open tubes and right into that highly efficient solid medium. Which leads us to Step 4. Those sounds hit the chest wall dramatically amplified. The pathway is perfectly preserved, but the acoustic medium has just been upgraded from air to solid. And guys, that mechanical cascade gives us this entire cluster of clinical signs. Let's break them down. Increased vocal fremitus, that's just palpable vibration felt through the chest when a patient speaks, which is amplified because, again, a solid medium transmits physical vibration better than air. Bronchial breathing, that is literally just the harsh central airway sound arriving at the chest wall without being naturally filtered. Increased vocal resonance is just louder spoken words for the exact same reason. Aegophony, which is where you ask the patient to say E, and it sounds like a nasal A through your stethoscope, is just the solid tissue selectively distorting specific sound frequencies as they pass through. And of course, our hook from the beginning, whispering pectoriloquy, where the quietest possible sound is clearly transmitted through that highly conductive solid block of tissue. Every single sign here is just physics in action. You know, it's really fascinating. This whole acoustic phenomenon has an exact visual equivalent when you look at a chest X-ray. It's called an air bronchogram. It's a radiological signature where you can clearly see the dark, air-filled open bronchi just standing out against the bright white, opacified alveolar tissue. It is the literal visual proof of exactly what you are hearing. The airway is patent, but the surrounding spongy lung has become a solid mass. Let's jump into Section 3. Lobar collapse and tracheal shift. Here we see the exact opposite mechanics.
If consolidation is all about an open airway and a solid lung, what happens when we totally flip the script and change the mechanics completely? Notice the sharp mechanical contrast. In consolidation, the airway is patent, sound gets amplified, and the physical volume of the lung lobe is preserved. But lobar collapse is the exact inverse. In a collapse, the airway is entirely obstructed, and because that airway is blocked, air can't get in, sound can't get in, and the lung lobe just shrinks down, completely losing its volume.
Let's zoom in on the mechanics of that collapse for a second. It always starts with something physically blocking a bronchus. Maybe it's a tumor, an inhaled foreign body, a mucus plug, or even an enlarged lymph node pressing from the outside. Because that lobe is no longer getting ventilated, it deflates and shrinks down, kind of like a let-down balloon. This massive volume loss creates a vacuum effect, and that actively pulls the trachea toward the affected side. And since there is no open airway pathway, and the tissue is just this dense, collapsed, airless mass, it becomes a terrible conductor of sound. So totally unlike consolidation, breath sounds here are dramatically reduced, or even absent.
And this comparison brilliantly illustrates how we can separate these conditions right at the bedside. Let's look at the big three: consolidation, collapse, and a large pleural effusion, which is fluid around the lung. First up, percussion. They all cause a dull note when you percuss or tap on the chest, right? Because in all three, you are tapping over something that is not air. But look at the breath sounds. Consolidation is the absolute only one that increases sound transmission. Both collapse and effusion decrease it. And what if you need to separate a collapse from an effusion? Well, just look at the trachea. A collapse loses volume and pulls the trachea toward it. A large effusion takes up extra space and pushes the trachea away. So just by understanding the underlying physics, you can triangulate the exact diagnosis every time.
All right, section 4, the obstructive pneumonitis trap. This is a really dangerous one.
We definitely need to discuss a vital clinical pearl here. When you hear those signs of consolidation, it's super easy to just assume, oh, it's a standard bacterial pneumonia. But obstructive pneumonitis happens when an endobronchial tumor, very often a non-small cell lung cancer, partially or completely obstructs a bronchus. This obstruction leads to a pooling of secretions and localized inflammation right behind the tumor. So on a chest exam, this creates a consolidative picture that is physically indistinguishable from a standard infective lobar pneumonia. I mean, the stethoscope is going to give you the exact same acoustic signs.
And this right here is exactly why treating the patient, and not just treating the physical sign, is absolutely critical. Imagine patient A. They are cachectic, they've lost weight, they have a heavy smoking history, maybe you even see some finger clubbing. If you hear consolidation in a fixed anatomical spot on them and it keeps coming back, that points strongly toward a bronchogenic neoplasm hiding right there in the airway. Now contrast that with patient B. They have a rapid, acute onset, they are tachycardic, maybe they're running a high fever with classic infective symptoms. That points toward your standard lobar pneumonia. The chest acoustics are identical for both. It's the surrounding clinical history that actually separates a easily treatable infection from an underlying malignancy.
Okay, section 5. Updated pneumonia treatment guidelines and evolving CAP management.
So when it actually is a true community-acquired pneumonia, how do we manage it in modern practice? Well, the foundational framework we still rely on today comes from the 2019 ATS/IDSA guidelines. They really emphasize assessing severity, getting cultures before antibiotics when feasible, and treating based on specific risk factors. But as we know, clinical practice never stands still. By 2021, we saw a massive push toward incorporating rapid molecular diagnostic testing to identify pathogens way quicker. Then by 2023, we got highly refined, updated evidence clarifying exactly when we should be using corticosteroids for specific, severe presentations of pneumonia. And today, the overriding theme across the board is antimicrobial stewardship. We're moving away from reflexively prescribing broad-spectrum antibiotics and instead targeting the therapy specifically based on local resistance data. The science is just always evolving.
And wow, that brings us right back full circle. Clinical medicine, when it's at its absolute best, isn't just a textbook of random facts you have to force into your brain. It is beautiful, hidden physics applied directly to human anatomy. When you just know that sound travels faster through solids than air, you don't have to memorize a list of signs for consolidation or collapse ever again. You can literally just close your eyes, picture the mechanics happening beneath your stethoscope, and deduce the answer every single time.
So I've got to ask you, what other purely memorized medical facts do you think are actually just hidden physics waiting to be understood? Think about it, and let me know down in the comments. If this explainer helped you finally conquer chest acoustics, please hit that like button. Drop a comment with your biggest aha moment from today, and definitely suggest what complex medical topic we should break down next. Make sure you subscribe so we can keep learning together from first principles. Until next time, stay curious.